Right. Then you're going to start by saying, right. And you're like, I'm way more than third question. Yeah. Yeah.
I can see Lauren. I don't intend that it happens. Not coffee. Well, we're just expecting one more commissioner. Give him a couple minutes.
It'll be on the
Good morning. Welcome to the October 18th Joint Committee meeting of Care Delivery and Payment System Transformation, Quality Improvement, and Patient Protection Committees. Before we begin, I just want to acknowledge that this is the last committee meeting of my co-chair, Dr. Carol Allen, and I just want to thank her on behalf of the QIPP committee for her leadership over the last 5 years on the Health Policy Commission. It's been a real pleasure for me to work with Carol, and I appreciate all that she has done for not only the commission but for the Commonwealth. We have a couple of presentations today and an update on the ACO certification program, PCMH Prime, and some proposed changes to RPO reporting requirements that we'll get into at the end. First, we have the minutes of Wednesday of the joint committee meeting that was held on Wednesday, June 7th, 2017. I have a motion to approve the minutes. Second. Any discussion? All those in favor? Opposed? The minutes are approved. Our first order of business is a presentation by Kaitlyn, Kenney, Walsh of the Blue Cross Blue Shield Foundation of Massachusetts. I had the pleasure a couple months ago of hearing a briefing to other health funders by Kaitlyn, and immediately shot off an email to the staff here and said we need to have her present to the QIPP committee because Blue Cross Blue Shield, the work that they are doing on mental health policy and research is really cutting edge and very important to the work that the commission is doing as well. So we invited Kaitlyn to come and present this morning. Kaitlyn oversees policy and research at the Blue Cross Blue Shield Foundation of Massachusetts. She formerly was Director of Policy and Research at the Commonwealth Health Connector, and also served as a Rappaport Public Policy Fellow in the Office of Senator Richard Moore. And it's my pleasure to welcome you.
Thank you very much. Thank you for having me here today. Thank you to the commissioners for welcoming me. Thank you to the Health Policy Commission staff for having me here today. It's my pleasure to be here with you. My name is Kaitlyn Walsh, as mentioned, and my role is to oversee the policy and research agenda at the Blue Cross Blue Shield Massachusetts Foundation. Today I'm here to tell you a little bit about the foundation. I think telling you a little bit about what our mission is and orienting you to that mission which guides our work will be important context for you as I move forward, in particular as we think about the work of the foundation, how it relates to and is similar to the work of the Health Policy Commission, and also thinking about where our scopes might differ a bit. I'll also speak with you briefly about a strategic refresh process that we went through, which really is the process through which our focus on behavioral health and the work that Marty mentioned evolved from that process. I'll dive deeply into some of the projects that we've completed in the space of behavioral health. Some of them are projects that I think you'll be well aware of, and I'll try to spend the bulk of my time talking a little bit about the emerging projects which we hope to release at the end of this month, and the projects that we foresee coming down the pipe for the next calendar years. Again, I think there's a lot of synergy between the work that we are doing and the work that the Health Policy Commission is doing, and we're privileged in that we have a good collaborative relationship in order to sort of leverage the work that we're doing to maximize our impact. I'll pause at the end for any questions you might have, but also happy to answer questions along the way. So many of you might be familiar with the foundation. organization, but I'm not sure that all of you are. So again, thought it would be helpful to orient you a bit to our work and our scope and the area in which we primarily practice. Our mission is to improve access to care for low-income and vulnerable people in the Commonwealth. We do this primarily through two different organizational arms. We have a grant-making arm, and that arm really won't be the focus of my conversation today. It's overseen by a colleague, Celeste Lee, and provides some direct support into the community, funds a range of different programs and partnerships, including support for community-based organizations, really just to provide operating budget support so that they can continue to advocate for important policies that do promote access to care, particularly for vulnerable populations. We also have support in that program for connecting people to public health insurance enrollment, helping them to maintain their coverage and provide post-enrollment support services. We have a particular grant program in place right now, which won't be the focus of my conversation, but merits a note here because it does relate so much to our work. It's a program known as Fostering Effective Integration in Care. It's a program designed to support really advanced practices and programs that are intending to promote access to services through the integration of primary care and behavioral health care services. It's a 3-year program. We are wrapping up the end of our 2nd year of that program. Next year will be the 3rd phase of that program. That program does involve an evaluation component with John Snow. And again, my colleague Celeste would be able to provide you more detail on it, but I highlight it because it's certainly relevant to some of the investments the Health Policy Commission has made as well. Really the focus for me today is on our policy and research agenda. The policy and research work that we do ranges from producing publications and reports intended to provide educational and objective information, particularly on policies and issues impacting low-income and vulnerable consumers in Massachusetts. In addition to that, we do a host of convenings intended to help disseminate that information, but also to bolster consensus on important issues. Perhaps the Foundation is best well known for some of the convenings it did and policy work it did around the roadmap to coverage. So what are the focus areas of the Foundation under that mission? It's broad, and so we sought back in 2013 to undergo a strategic refresh process where we could identify particular areas to concentrate our work as we move forward. And through that process, which we engaged in with our board, we really identified 3 primary areas upon which we wanted to focus our investments in both our grant making and our policy and research work. These include care and coverage, social equity and health, and behavioral health, which again is where I'll focus my comments today. As you can see here, just in this illustration and in terms of the topics that we tend to focus on, again, there's a lot of synergy, I think, between the work of the Health Policy Commission and also a lot of the other agencies and organizations in Massachusetts really focusing on this important work right now. I thought I'd walk through some of the recent releases that we have issued relating specifically to behavioral health care to provide you just a sense of the type of work that we do. But again, I'll focus my comments and leave ample time at the end really to talk about the emerging study that we have looking specifically at access to outpatient mental health services. Our work has really focused in the behavioral health space to date on integration and then also particularly on issues of access. So the first project that I'm sort of identifying here in this group of projects, really, we're very much focused on integration-related work. The first project involved a sort of secondary analysis of existing reports, commission letters, checklists, etc., and sort of synthesized across those. What are the known barriers right now with respect to licensing, privacy, or reimbursement that organizations are experiencing in their efforts to try and integrate care? We then took that synthesis of information and we leveraged our relationship with the grantees that we work with for our grant-making program and asked them to help us prioritize, to help us understand, if we looked at all of these issues that are raised, what are some of the issues that, if addressed, would best help efforts and best improve and impact access to integration of services. I think you wouldn't be surprised at what we heard. Issues like reimbursement rise to the top of the list. Challenges in terms of lack of reimbursement for things like form handoffs, care coordination, etc. We also learned from that work that another key challenge is privacy laws, or lack of understanding in terms of the degree to which privacy laws preclude the sharing of information across providers, as well as operational challenges, even when perhaps information can be shared, health record systems' inability to make that information readily transferable across providers. So we took the learnings from that report, and it really led into the next project, which you see here, where we partnered with Manat Health, a legal firm, to look at not only the state level requirements that really impact the sharing of information across providers, but also federal rules. And our goal here again was to provide an educational resource to practitioners and others in the Commonwealth to really better understand and level set what the rules are in terms of information exchange. I think many of you have often heard HIPAA is often cited as a barrier to sharing information. And one of the things we heard through our grantees and also in doing this work with some legal consultants is HIPAA may not actually always be the barrier that people allude it to be. In fact, it's sometimes referenced in instances where it may not be the biggest barrier. Interestingly, this report highlighted that 42 CFR Part 2 is certainly an issue, which is a federal regulation that creates some challenges, but also that there is a panoply of state laws pertaining to mental health regulations, and the way in which they're sort of applied creates some uncertainty for individuals in terms of to what regulations they're subject to. And often when there's uncertainty or ambiguity, most conservative interpretations apply. So our goal was really to highlight some of this in hopes of drawing attention to areas where at least where we can assume some action at the state level, perhaps there'll be some clarification around it. And lastly, the project highlighted here included a case study of 3 different health centers in the Worcester area that were trying to implement different care coordination and integration efforts to better improve access to services for individuals in these health centers. Included a quantitative analysis of Medicaid claims data for individuals using services at these institutions, and also qualitative interviews and focus groups with providers and other administrators to really understand, what are they doing to help improve care. Again, I suspect that the findings from this won't be surprising to you. It's things like offering supportive services, being flexible in terms of your scheduling, types of services that are most appreciated and needed by patients in complex situations with complex needs. In the access space, a couple of reports I'm highlighting here. A couple of years ago, we worked collaboratively with the mayor's office in an effort to really understand the need and demand for services, particularly in the addiction and recovery space, specifically in the city of Boston. Through this report, we convened an advisory group to really try and better understand what the needs are in the community. Not surprisingly, it's challenging with data to get information that's particularly specific to a local area. We relied on purpose data and data from the National Survey of Drug Use and Health. Again, really challenging to get information that is local. So we supplemented that with some qualitative data, and the report concluded with a roadmap for the mayor's office to really try and identify ways in which they could set up an Office of Recovery Services to promote access for addiction and recovery services in the Commonwealth, and indeed an office was set up shortly following the release of this report. Most recently, we released a report that was intended to serve as really a foundation for future work in the behavioral health space. We're calling it The Basics, and it's really designed to provide some foundational information on what are prevalence rates of particular mental health and substance use disorders in the Commonwealth across a range of demographics. What are some of the policy initiatives that have taken place at the state level and the federal level that have impacted access to outpatient and inpatient mental health and substance use disorder services? When we talk about behavioral health, what type of providers are we talking about? What type of services and settings are we talking about? What do we know about the workforce and the system capacity? We were able to leverage some data from Health Policy Commission and reports that you all have issued to speak a little bit to affordability, particularly as it relates to individuals with co-occurring disorders. And lastly, we pulled together information on the range of different quality indicators that are being collected across organizations and agencies in the Commonwealth. We concluded really with something we sensed before we started the project that became really critical as we dove into the project, which is there still is a dearth of data on behavioral health care services, capacity, quality in the Commonwealth. And so the report concludes with some suggestions of information that would really improve our ability to address our access concerns moving forward. So coming soon, as you can see here, these reports are embargoed, but I'll speak really to what has been one of our most comprehensive investments in time and resources on the policy and research front in the behavioral health space since going through the strategic refresh process in 2013. Recognizing that the field of behavioral health is broad and recognizing that we really need to focus our efforts specifically, we met with a group of advisors to understand what information would be useful to policymakers to help inform the dialogue and move policy forward in improving access to behavioral health services. What we heard from that group is there's a lot of anecdote that abounds around what it looks like actually waiting for services, but there's not a lot of data that people can point to that's been collected in a systemic way. And having that data would be helpful to policymakers to bolster their case for modifying the way we do things right now and considering different policy options. So the report that we'll be releasing at the end of this month at an event on the 31st really sought to understand what is the experience of Massachusetts residents seeking outpatient mental health services. We used a mixed methods approach to really try and garner information from a variety of different sources and triangulate an understanding of this issue. The research that we did was conducted in collaboration with APT Associates, which is a firm located in Cambridge, Massachusetts. It included qualitative data collection. So we included focus groups with individuals and parents who had sought outpatient mental health services in the last 6 months. We sought to have focus groups that included individuals who have both public insurance and also individuals who have commercial insurance who were able to pay on their own outside of their insurance for the services that they needed. In addition, we had APT conduct 24 different interviews with stakeholders who have sort of a vested interest in and are very involved in the mental health system in the Commonwealth. And we also supplemented that with 2 different provider surveys in order to get a quantitative sense of what the picture looks like in terms of access to outpatient mental health services in the Commonwealth. So our provider survey was a survey that leveraged licensing data. So we looked through BORA, the Board of Registration and Medicine data, and through the Office of Consumer Affairs and Business Regulation data to pull addresses for all licensed mental health clinicians in the Commonwealth. So not just MDs, but also social workers, psychologists, etc. And we sent the survey through a stratified random sample to try and get a representative sample of mental health providers in the Commonwealth who were successful in being able to do that. And the goal of the survey was really to get a sense from the perspective of a provider of what the average wait time is for a particular service, specifically an initial outpatient mental health visit. And we asked a host of questions along with that around whether that wait time varied based on the type of insurance an individual had. We asked some questions around if an individual provider indicated they didn't accept a certain type of insurance, what the reason was for that, etc. So our goal was really to paint a good understanding of access to care and factors that drive access to care among outpatient mental health providers. On the organization survey side, given our mission and our focus on low-income and vulnerable populations, we wanted to be sure that we oversampled safety net settings. So we partnered with the Association of Behavioral Health Care, we partnered with the League of Community Health Centers, and we distributed our survey by web to organization administrators at community mental health centers, organizations that serve predominantly mass health clients. We asked similar questions to those that we asked in the provider survey, intended to really understand what a wait time looks like for an outpatient mental health visit. I can preview some of the results for you here. I don't want to steal our thunder for the 31st, so I won't do all of the big takeaways. But I will tell you that in some ways we weren't surprised at all. So some of our hypotheses were proven true. And in other ways we were quite surprised. So things that we had anticipated as we went into the study. We expected to hear that wait times would be excruciatingly long. and we expected to hear that psychiatrists would be particularly challenging to access. We expected that it would be especially challenging to seek services for children. And we weren't sure what to expect in terms of differences across provider types, with the exception of thinking psychiatrists would be a challenge. And we didn't know what to expect with respect to regional variations in access to services. I think the big takeaway that emerged from doing this work and doing it in a mixed methods way for us was that often what you hear from different perspectives or from different stakeholders is variable. And so then you have to take the data together and really try to understand why it may not exactly line up as you anticipate. What I mean by that is, when we had our focus groups and we had our stakeholder interviews, the vast majority of people that we spoke with said that wait times were very, very long and that the process was incredibly challenging. When we got the results of our provider survey and our organizational survey, the results were quite surprising. In fact, the majority of providers or organization administrators reported that they were able to see patients within 2 weeks. It was quite different than what we anticipated. It caused us to grapple a little bit with the results and think through, what's the story here? Why is this happening? Why don't these sort of align as we would have anticipated? And I think one of the things that we've come to the conclusion is that part of the challenge here is that consumers and stakeholders start thinking about a wait time as the minute a need for a service is identified. So whether it's through the school system, through a visit with the PCP, the parent recognizing a need for a child, it's at that moment in time that the clock starts ticking. And there is a long process that involves challenges with actually identifying providers, contacting providers who don't call you back, contacting providers that may not have the right expertise, contacting providers that may not accept your insurance, contacting providers that don't have appointments available when you need them, etc. And all that time counts for a consumer or a stakeholder. But when we get the survey back from an organization administrator or provider, all that time sort of counted out. Just counting, okay, I've spoken with someone who's connected with me, I'm a viable provider, and once they reach me, yes, I can potentially see them within 2 weeks. And again, this isn't for all patients, but it was surprising that for the majority of patients, on average, this was the story that we were hearing. Some other findings, again, I think we'll preview more at the event at the end of the month. But again, wait times for psychiatrists are particularly challenging. Again, the differentiation between psychiatrists and other providers may not have been as large as we would have anticipated, but there is indeed a difference, and psychiatrists do have longer wait times than other providers. And not surprising to us at all, parents are really struggling to find providers for their children. I think a couple of other things I'll mention before moving on and pausing for questions. One thing that really struck me in speaking with stakeholders and speaking with friends and speaking with people who are seeking services, it's very common to want a provider with particular expertise. So you want a provider who has experience treating PTSD. You want a provider who has training in a particular type of therapy, CBT or whatever the case may be. And people often describe that as really challenging. It's hard to locate a provider that has that expertise. Interestingly, and that resonated as well in our focus groups and in our stakeholder interviews. Interestingly, and perhaps to our surprise, we asked our providers and we asked the administrators and organizations to report on, the types of expertise and credentials and experience they had. And we were quite surprised to see the prevalence of providers reporting expertise in children, in particular types of therapy, in treating patients with PTSD. And so again, that suggested to us that there might be some challenges in terms of both the credentialing process and also the process by which we identify providers and communicate that to patients in terms of expertise that are available to them and who has that expertise. So I'll pause there on this and happy to answer more questions. We will be sharing more on this again at the end of the month. We have 5 different reports that will be coming out summarizing the work that we've completed here. I'll tell you a little bit about some of the projects we have in development again, and then pause for questions. In addition to these projects, we'll also be fielding our 2018 Massachusetts Health Reform Survey. Many of you might be familiar with what we call the MHRS. It's a survey of non-elderly adults in the Commonwealth. It's been in place since passage of Chapter 58, the state's health reform law. This really serves as a systemic way to track not only insurance coverage, but issues of affordability, access challenges, factors that impact access, etc. One thing we're really excited about is that we'll be adding a cohort of questions speaking specifically to mental health and substance use disorders in this survey this year, and that will be the first time that we'll be incorporating such questions. Again, questions not so much focused on prevalence issues, because I think BRFIS and other surveys adequately capture that. It's not so germane to our mission, but more focused on for people who identify a mental health or substance use disorder condition or need. What are do they experience challenges accessing care, and if so, what are some of the challenges and what are some of the barriers to that care? And we're also in the process of developing a project that would really help us to understand, based on sort of a synthesis of best practices across the country and also things that are in place here, what a model behavioral health system might look like. Part of the project envisions sort of looking at what some of those model components are, what's in place currently in the Commonwealth, and what the gaps are from what we currently have to get to that type of model system. Both of these projects, the first is further along than the second, but just wanted to preview for you the types of projects that we have coming down the pike in this space. I'm happy to pause and answer questions, yes.
Thank you very much. That was a lot in a short time. What I was going to ask is, based on your research, did you have some solutions to suggest? So is number 2 here the solutions part, or are there any things coming up sooner about potential solutions for mostly for access, I guess, and just design of systems, or just for example, it seems to me we should be using technology more to link people together. Is anybody looking into doing that so that you could actually find the right provider and match people up more easily?
That's a great question, and I think the question you ask is exactly in line with our thinking, which is, okay, we're not going to spend any more time documenting the problem. Certainly we've reached some mixed results with our responses, but we don't think getting to a greater precision is worthwhile at this point. We know there's a problem. So in terms of solutions, our report summarizes some of the solutions that we heard from stakeholders. The foundation itself isn't in a position to advocate for particular solutions, but we're able to sort of put forth options for consideration. Some of those options include things like you're saying, things like better reliance on technology to promote access to care, things like modifying the payment system such that we are able to account for some of the sort of warm handoffs, care coordination, et cetera, that better improves integration and connecting people to actual services. Some of the other solutions are revisiting some of the insurance requirements associated with getting on an insurance panels network. We understand from this research that particularly for mental health providers, many of which are disproportionate number of which practice in their home offices or in private offices, the burden associated with some of that paperwork might be enhanced. Some of the other solutions, I'm trying to think of some of the other items that we flagged, but there is a section designed with those, and I would say at this point and at the event that we are planning, the second part of the event, which Martin can speak to as well, is really intended to start flagging some innovative models, either care programs or resources that are specifically targeted towards improving access to behavioral health care services. And they include, for example, one of the programs that the HBC is funding at Riverside, Visa Telehealth, as well as a resource known as the Interface Referral System, and also the STAR program, which is using open scheduling as a sort of care model to promote access.
Kaitlyn, one of the areas that we have focused on is reducing ER use. And the question always comes up, what's the relationship between the outpatient behavioral health system and increased use of ERs for behavioral health needs? Is that addressed in the upcoming report, or is that the next? Is that possibly another research question for that?
Yeah, it is not addressed in our report. I think there is a sense that there is a direct relationship between lack of outpatient capacity and increased utilization of ED for behavioral health related visits. It's a topic we talk a lot about with HPC staff. I think it's something we can continue to explore moving forward in terms of who takes facility, where do we go with that, et cetera.
I sort of wanted to pick up on this news, how that works, because these problems are really, really common. Are there any areas around the country that have addressed either the scheduling issue or the staffing issue or the connection issue or anything like that that people know about?
So it's a good question. It's certainly a space that we continue our vision moving forward with. Interestingly enough, I think that's the type of issue that we would look to address and incorporate into the project I flagged in terms of what does a model behavioral health system look like. The sort of downside answer that I will say to you is, as much as we talk about the challenges that exist in Massachusetts, when you compare us nationally, a lot of places say we look really good. And so I certainly think there are models out there. There's a program in San Antonio, Texas, where there's a much better integration across agencies and facilitation of direct connection to supports that's worth looking at further. And so I would say we're preliminarily looking at things, and that will be teed up more in the project that I flagged as sort of model behavioral health systems. But I'll also say it's challenging because places don't look that wonderful outside here as well.
I'll stop that. So I just had a quick question. I don't know if I'm sure you haven't had a chance yet to read the 100-something page bill that came out of the state senate yesterday. Some people are not here because they're doing that currently. But one of the things that I noticed was that they have this new licensure process for behavioral health urgent care facilities. I'm wondering, is that one of the recommendations that came out of your earlier studies? Is that begin to address some of the licensure issues, or what your comments going to be about that provision without trying to make sure in the spot in the Blue Cross Blue Foundation?
I completely appreciate the acknowledgement that I'm speaking from a foundation hat, not a company hat. That's always an important distinction to make. I would say that the topic that you're mentioning in terms of some of the urgent facilities for behavioral health treatment it's a solution that was raised in some of the discussions we had with folks who advised this project. And I think and so this is anecdote and not sort of a systemic collection of data or information, but one of the things we've heard around amongst the many folks we talked to is such a model where urgent care for behavioral health conditions is available, akin to the way in which you can call your general medicine doctor and say, hey, I have an issue today and I need to get in and see you today, is the same type of service model that needs to be transferred to the behavioral health space. And there are some examples of ways in which that's being adopted. The STAR program has some innovative approaches like that. And so I would just say anecdotally, it's something that has begun to develop a bolus of support, but I can't speak to the efficacy of the model to date. Thank you.
It's actually Jamie's turn. Okay, so I guess I will celebrate in the 5 years that I've chaired this committee, the accomplishments of PCMH and ACO certification standards. And we've come a long way, and thanks to the hard work of our staff. So today, we're going to just briefly touch on what's next for ACOs, and then go back to look at PCMH and how is it moving next? What are the modifications that are in store for us, which are positive and not very complicated actually. I don't know if there's anything
So Katherine's going to take us through the ACLC and Kelsey Brakeman, our Senior Policy Associate on the PCMH program, will help take us through the PCMH part. I will just preface the ACO update with, we just got the applications in. They are about 200 pages, so we can't really answer any concrete questions about what's in the applications, and of no surprise, all systems ask that we keep that information confidential. So we will not be able to sort of name systems and system competencies with regards to the ACO certification. But that being said, great.
apologize for you.
So, Commissioners, when the committee last met in June, you might recall that we were about to open our platform and start taking applications. So we did that on June 9th, and over the summer we worked really intensely with the ACOs to support them through the application process. And that included issuing weekly FAQ documents. We had office hours phone calls where systems could get on the phone and ask us questions both about the application process and about the content of the standards themselves. And through that, we made it through the other end. Our deadline for submission was October 1st, and we have received 15 applications for certification. That's in addition to the 2 that we, you might recall, had previously certified, Community Care Cooperative and Boston Accountable Care Organization through our early kind of beta launch test of our system. So we're now in the process, as Katie just said, of reviewing the applications. That's quite an intensive process for us internally with a completeness check and then a couple of rounds of review and reading the applications closely. So we're working on that now with the goal of finalizing certification decisions by the first of the year. And after that, we'll move into, hopefully a really interesting and meaningful phase of this program where we'll be able to begin reporting out, obviously subject to the appropriate confidentiality protections, on what we've learned from certification. So we're in the process now of thinking about what are some of the interesting, in aggregate, sorts of data that we can pull out and share. And we're really looking forward to that analysis. I think this is a long time coming, and we're looking forward to the time that we can really dive into the content and start learning from this program the way it's intended. So that's where we are now, and the next slide is really just an overview of the organizations that submitted applications to us. Essentially, this is coupled with the 2 additional ones that we certified in beta. This represents the universe of systems that have a contract with Mass Health. So we got applications from everyone that we expected.
Looking back at the minutes from June, you were expecting about 20 and you got 18. But I know that there are a couple of large systems in our state in our Commonwealth that are not on this list. So a couple of questions going forward. One is looking at, is it possible, I asked the staff this, I guess, in a de-identified way, it's possible to highlight best practices or successes that different ACOs are doing so that we can learn, or other systems can learn from that. That's one question, or one comment. Do you think it's possible, or are you planning to compare any kinds of metrics or benchmarks or outcomes of all the certified programs with some of the ones that didn't? Not certified, to look like a control group almost.
Yeah, I mean, the first part of your question, I'd say it's certainly our hope that through, mining the information we get for certification, we can start to pull out some interesting, promising kinds of programs and approaches that ACOs are taking. I think it will be a little while before we're ready to say that's a best practice, and I think at the outset our criteria are a fairly baseline, set of competencies, and so it will take some time, I think, for the program to evolve to a level of maturity that we have that kind of, sort of, not purview, but analysis of it. As for the second part, it's an interesting idea. I think we will be able to think about how do the systems that we've certified, how might they compare to the broader landscape. Getting data on those systems that haven't submitted for certification could be one challenge, but something worth thinking about.
I also would add that, not surprising to us, the universe of systems is exactly the universe of systems that is participating in Mass Health. That is our main leverage point right now. But that being said, there are other leverage points that we have. So the Department of Public Health regulations around determination of need for ambulatory surgical capacity. They have to be partnered with or appropriately affiliated with a HPC certified ACO, and so any system interested in building ambulatory surgical capacity needs to go through that, and the connector had put it in their seal of approval process. And so, we continue to work with agency partners and private payers in the market to think about how we can continue to move the needle on a consistent set of care delivery standards for ACOs in the Commonwealth. I don't think that this is the full universe of ACOs that will be participating in our certification process. We'll see what next year brings.
Other questions?
So, I'm trying to, so there are a bunch of functions here. There's a sort of certification function, like you actually have the things that you say you have, that you say that the Commonwealth says you should have. And then there may be a sort of pushing them in a particular direction or helping them out function here. And I guess I wonder, to what extent is this kind of certification like, okay, we know you need to be able to do X, particularly to participate with this set of patients. So therefore we want to make sure you do have X. And how much are we saying, no, here's actually a really good way you could do this. And so as part of this process, we're going to introduce you to some of this and try to move you in a direction that's helpful.
Yeah, I think that's the main tension that we are finding in evaluating these applications. The best example that I can come up with right now is that most of the commercial governance structures within ACOs did not include patients and families. Nobody said that they had to. Medicare said that they had to, and Mass Health said that they had to, but not for the commercial. And so in that instance, we said you have to have patient-family engagement in your governance structure, and so they largely had to make a change in order to do that. We decided that that was a best practice. We are more encouraging them to do that. In my opinion, this program is a care delivery transformation program. It is not a market program. It is not a quasi-regulatory program in any way. So the whole point of it is to be able to partner with systems and move them along their accountable care continuum. But we continue to face that philosophical tension and how much do we push and how much do we partner through this program. David, sure.
And just to add, part of the structure for the certification program was there's some that were assessing whether they have these criteria or not. We're saying you have to have these criteria just to be certified. And then there's a whole laundry list of things that we had supplemental information. They have to respond to us, but we're not saying you have to have a presence of this or not. So I think a good example, David, to your point around how can we use this information to help fill out our policy agenda, just as for example, one of the supplemental information requests is around what are you doing around end of life and advanced care planning? And if we get, all of these applicants and we see that 0 out of 18 ACOs are doing anything around end of life or advanced care planning, I don't think that's what's going to happen. But say we saw those responses, that may be a place where we as a commission or as a Commonwealth say, we need to do some work here and help these ACOs be able to advance in this space, because the next time around when we do certification, it may not just be a request for information, it may be a prerequisite for certification. And so that's how this can evolve over time and push the ACOs to get to a higher level where we want them to be.
David, do we have a technical assistance strategy in conjunction with Mass Health to do just that?
Sort of. I think there's a lot happening right now, and Undersecretary Peters can probably speak more eloquently to this than I can, but Mass Health has a huge agenda around the district program, and the money that systems are eligible for the district program, and then a TA program that is wrapped around that district program that are 7 different competencies that systems can apply for TA, and so there's a lot going on, and so I think our position on it is that we definitely want to be able to help and support systems along their journey. But what we've heard is that there's a lot going on right now, and so maybe sort of next year revisiting that topic and thinking about how we can best help. What this is accomplishing, obviously, it's just for the Mass Health population, and we would have an all-payer view. So that's our
Can I just flesh this out a little more, because I want to link it a little bit to the discussion that Kaitlyn started about the behavioral health stuff. One of the things we could do is say, look, on the basis of what we know, here's some ideas on how to do behavioral health integration well. You know, here's what we've learned from either other areas or from other insurers or ACOs or whatever about it. And I don't know. I mean, there may be only a few areas for which that kind of thing is relevant. Behavioral health may be the clear example where they don't work anywhere near that. So it may be that in some of those we can say, look, you don't have to do it, but here are some options here are some things that other folks have done that have actually turned out to be very important or very valuable for them.
Yeah, the population health management criteria does require them to tell us about behavioral health and or an SDH for the social determinants of health program.
Yeah.
You know,
But I
I
think
will
also about giving them advice. That is,
absolutely, and what we've seen in our, again, I said I wouldn't speak to preliminary, but
Yes.
I will go ahead and go back on my word.
you know, you've read all
That
18
they're-
times 200 pages.
But they're across the board. We're quick readers. They're really across the board. Some systems do it really well, and some systems it's clear that there's not a cohesive strategy there. So there will be a lot to put out once we're done discussing.
And just also note that the Mass Health strategy for these 17 includes a community partner.
Absolutely.
So there's actually work being done at that level.
Yeah, and sort of TA and funding through the district program directed for community partners for the serious mental ill and the LTSS populations.
To the extent that we identify new models and best practices, and to David's point about it, we view this as an evolving process. So we hope that if there are some models and best practices that are identified, we could incorporate them in, work with the agency to build them into the criteria or some of the guiding principles.
I should also say, as we've always talked about, balancing burden with, with rigor, I guess. So, I don't think we're abandoning that here. So the fact that there are 15 applicants doesn't 100% mean that 15 will be approved. They still have to meet our criteria. I've heard from the staff that there's going to be a lot of back and forth and how people can, improve their applications and what they're doing. But we'll see. We'll see what happens. It's important that we maintain the standards that we have set. Thanks. Thank you. Have fun.
We have our work cut out for us.
We do have your work cut out. So switching over to PCMH.
Great. So under our PCMH Prime program update today, there are a couple of key topics that we'd like to discuss. First, I'm going to take you through just kind of a program update and an overview of the numbers of our participating practices. And Kelsey's going to take us through an overview of some changes that we've made to the PCMH Prime criteria and documentation requirements in light of the new NCQA PCMH recognition standards that are new for 2017. Then we're going to turn our attention to the PCMH Prime TA program and have a guest presentation and then talk a little bit more about some updates to that program. So just on the numbers, we now have 42 PCMH Prime certified practices. That's up from 37 that we reported to you back in June, with 2 sites from Charles River Health Center, Upham's Corner Health Center, Bowdoin Street Health Center, and the general internal medicine practice at Boston Medical Center, all achieving certification in the last couple of months. We have 65 practices that are actively on the pathway to PCMH Prime, and 1 that we know of that is working concurrently right now toward PCMH Prime certification and NCQA PCMH recognition. So altogether, it's exciting to pass the 100 mark for the total number of practices participating in the program, and we're looking forward to having even more as they come in. So now we're going to spend a little bit more time on the PCMH Prime criteria themselves. And as you know, commissioners, the program has 13 criteria that are all related to specific behavioral health integration capabilities. And these criteria have always been a mix of standards that are included in the NCQA PCMH recognition program, plus some additional standards that were created and developed here at the HPC. So since NCQA recently launched their updated recognition program, some of the criteria that overlapped with ours have been changed. So of course, naturally that caused us to need to go back and try to maintain as much alignment as possible with NCQA and understand where they're going. So we're going to take you through some of the updates that we're making to the program in light of NCQA's shifts.
One of the marks of success or something good is the imitation. So basically, NCQA has thought some of the things that we incorporated were so good that they're putting them into their own requirements.
That's exactly right, and I think that is something that's worth kind of saying again, that we, as the commission did not feel like the NCQA PCMH standards were strong enough on behavioral health integration, and so that's why we sought to create this program. It provides some operational complexity when they decide to adopt our standards. They adopt it in a slightly different way, right? So just so that you all know, the NCQA PCMH levels are more like you have to meet a certain number out of a certain number overall. So it's not like you have to still meet these new behavioral health ones. So there still is value in this program, and it still is a higher bar than the PCMH program overall. But we were really pleased to see that NCQA is moving in this direction. The other thing that we'll revisit at some point, probably early next year, is they've also rolled out the behavioral health distinction module. Again, sort of at a cost to providers, and there's not necessarily a payment tied to it or any other incentive program. But it includes a lot of ours and more, some social determinants metrics in the behavioral health distinction module. And so we're working, again, through some operational considerations with NCQA as our contractor on this program to think about what that means for practices in Massachusetts.
All right, so Kelsey's going to summarize some of the key points around our change. So to align with NCQA's new PCMH program, I'm happy to say that we finalized and released an updated version of the PCMH Prime standards at the end of September. And these new standards will be effective starting November 17th. At this time, all practices applying for PCMH Prime certification must follow these new standards. So overall, these changes will impact the content or scoring of 3 out of our 13 criteria. For the remaining 10 PCMH Prime criteria, we have made some language or documentation requirements changes to align with PCMH 2017, but the content for those isn't necessarily different. So on this slide, what I've done is kind of compared back to back our current standards, or what I've referred to on this slide as our 2016 Prime criteria, with our updated standards, and what was marked here as the 2017 criteria. So overall, what you'll see is that the language is slightly different between the different criteria, but for the most part, the intent of the criteria remains the same. There are a few exceptions to this, and those are criteria 1 through 3B, which I've circled at the top of this slide. So for criteria 1B, under our updated standards, we've altered this criterion to more specifically focus on setting expectations for information sharing and patient care. For criterion 2B, the language remains the same, but we have altered the scoring. Under our current standards, we automatically give practices who achieve 2B credit for 1B as well. Going forward, we're changing this so there will no longer be double credit for achieving 2B. And the reason we decided to alter these two criteria in this way is because nearly all practices who have applied for PCMH Prime certification have in fact achieved criterion 2B. So what we're seeing is this criterion is not as difficult to meet as we initially thought it might be. So we think it's appropriate to raise the bar here. Additionally, we think that 1B is a capability that all practices should have
whether or not they need capability to lead. So our thinking that is for practices, even for practices that do have behavioral health providers integrated into their primary care practices, in all likelihood, they won't be able to meet all the behavioral health needs of all their patients. So they really still should be have the capability to coordinate with behavioral health providers and specialists outside of their practices. And finally, we also raised the bar a bit on criterion 3B. Currently, we require practices to track and follow up on behavioral health referrals. And going forward, we're going to continue to require this. But we've also added that practices should be monitoring the quality of referral responses. And this is to align with NCQA's criteria. So for the rest of the standards on this slide as well as the next, there are some language changes, but we haven't modified the intent of the criteria, so I'm not going to walk through them one by one. But I will pause in case anyone has questions about any of the specifics. Great. So on this slide, while the last one looked at the language changes between our 2016 and updated 2017 standards, this slide looks at how we've modified our PCMH prime documentation requirements. So overall, we've modified documentation requirements for 9 out of the 13 prime criteria. On the blue box on the left, we see that there are 4 criteria for which we've maintained current documentation. No modifications were needed to align with NCQA's PCMH 2017 requirements. In the middle box, you can see that there are 3 criteria for which we did have to modify them to align with NCQA PCMH 2017. You can also see that these are the criteria that I discussed on the previous slide. We had to make some modifications to reflect the new updated intent of these standards. And then lastly, on the right, there are 6 criteria for which we modified documentation, but also decided to differ a bit from NCQA's requirements. These criteria include our behavioral health screening criteria and our comprehensive health assessment criteria. We decided to diverge from NCQA's requirements by continuing to require that practices submit screening rates if they have the electronic capability to do so. This is something that NCQA used to require, but is no longer collecting. And we decided to diverge from NCQA here because we think collecting the screening rates is something that is important to the prime program, both to monitor practice performance on these screens, and also because we wanted to leave open the possibility for possibly setting screening thresholds in future iterations of the prime program. We wanted that option to be open. So I will conclude by just giving an overview of the impact of these changes. As Katie and Kaitlyn said, the big picture here is that we are more aligned with NCQA than the previous version of our standards were. Previously we had 8 criteria that were aligned with NCQA's PCMH program. With these new standards, we will now have 12 criteria that are aligned with PCMH 2017. The one criteria that is not in the PCMH program is our criteria requiring that our practice have a clinician providing medication-assisted treatment. However, that one criteria is in NCQA's behavioral health distinction module, so while it's not in their PCMH program, it is reflected in a different NCQA program. And then finally, I want to highlight that because NCQA is rolling out a new application system, we will soon have the capability to give practices automatic credit for PCMH prime criteria that practices have satisfied previously through their PCMH applications. This is something that we weren't able to do under NCQA's old application system, but this capability will help us reduce the administrative burden of applying to PCMH prime because it will help reduce the need of practices to submit the same documentation to multiple programs. So overall, specifically for 10 of these aligned criteria, practices applying to prime might be able to receive full or partial credit for documentation submitted to NCQA's PCMH program.
I think we are trendsetters, we should take credit. And congratulations on, really thoughts about it. It's really good.
Yeah, we're looking forward to discussing these changes more with practices. We have a training session. NCQA will be joining us in middle of November and doing a 1.5-day long training that includes their new PCMH 2017 standards, and we'll also have a half-day module on the new PCMH Prime program. So that'll be a good opportunity to start highlighting this new program to practices. We also had a webinar a couple of weeks ago where we started to introduce these changes. So,
Are we able to document or track, so practices that have accomplished Prime, that they actually are better integrating their behavioral health? Do we have data or looking for data on that?
we probably don't have that directly, but what I would say is that NCQA, part of their new program is also moving away from once every 3-year total assessment of everything to an annual review process. At this point, PCMH Prime remains a 3-year certification, but we have, I think, the opportunity to think about going forward, sort of mirroring what the NCQA approach is in terms of a more regular check-in on how practices are doing. The other thing I would note is that overall, NCQA's approach, they're really moving away from being very prescriptive about the documentation requirements. They're recognizing, I think, that applying to PCMH recognition has become a bit of a game, teaching to the test kind of situation, and they're moving toward saying to practices, you need to provide us with evidence that you're doing this. That could take the form of many different things. It might be a screenshot from your EMR, it might be a workflow, it might be a documented process that you have on the shelf. But I think in so doing, and in our mirroring those kinds of looser requirements in our standards, we're starting to set the expectation that practices really are not just being able to check the box and submit documentation once that meets the letter of the law, but are really accomplishing the spirit behind it.
I'll just add one thing there. And Katie, maybe you want to talk about this, but we're also, do have the ability to, through the APCD, map different types of utilization measures to practices. And so one of the things we've been considering is understanding, is there a correlated difference in terms of PCMH Prime certified practices versus non-PCMH practices? I think we're not suggesting at this point to say that there would be a causal link between saying, the fact that they're PCMH Prime has now led to these better outcomes, but are there certain characteristics of these practices that we can see in the data in utilization or patients that they're serving that is a correlation and something that we're very excited about.
Alright, so I think let's move on to talk a little bit about PCMH Prime Technical Assistance Program. We want to share some information and experience with you that we've gleaned from the first cohort of practices that have gone through our TA program. And in a minute, I'm going to introduce Myra Sessions, one of our TA practice coaches, to share some of that information. But first, just to remind you, commissioners, of what our TA program consists of, this slide is basically just an overview of our program. The first group of practices to sign up for TA got started last April, so they've basically finished up at the end of September. There were 20 practices total, and that's counting at the individual practice site level. We had 2 learning collaboratives over the course of the spring, really focused on teaching and the collaborative care model and the principles of collaborative care. We recorded and posted 7 webinars on specific topics related to the PCMH Prime criteria for practices to access at their convenience. We had 1 really insightful and engaging knowledge sharing session. These are peer-to-peer learning opportunities in contrast to the learning collaboratives, which are a bit more didactic. And the KSS that we had focused on the topic of MAT in the primary care setting, and was really a great event featuring speakers from Atreus CHA, Lynn CHC, and Boston Medical Center. So we've gotten off the ground with our KSSs, and all 20 practices that were included in this first cohort of TA also participated in practice coaching. So to tell you a little bit more about those practices and what they worked on, I want to introduce Myra Sessions. Myra is a senior consultant at HMA, working with providers and payers throughout New England to design and implement integrated models of care. Before being at HMA, Myra was at Commonwealth Care Alliance, there through the launch of the One Care program, and collaborated with primary care practices to achieve integrated care for members. She has worked at the Department of Primary Care at Brigham and Women's Hospital, collaborating with physician and administrative leaders to achieve the goals of the patient-centered medical home. And she has a master's in health policy and management from Harvard School of Public Health and went to Wesley. Myra has a lot of wisdom and also enthusiasm from various practice coaching experiences, and we're really glad that she is joining us today. She's going to share with you some more about what the practices worked on, highlight some of the successes that we had at the individual level, and then I'm going to come back and tell you a little bit about some updates that we want to make to the program in light of our experience.
What Kaitlyn didn't tell you is I have the most fun job. Of all the cohort, I believe, although I'm very grateful to Kaitlyn and Kelsey for really working with us as well as Kaitlyn on designing a program that made sense at the primary care level, but also to meet the goals of PCMH. So I think it was a real collaboration. So I just want to give you an overview of how we approached our technical assistance, our practice coaching. I think we have 3 goals, which we really tried to weave together into a cohesive program. So the first was to really help enable practices to achieve PCMH certification. I hope your numbers are going to go up. I know a number of the practices have applied for PCMH certification. So we really walked them through about where they were when they first enrolled in the program, and then which of the certification, the criteria were they interested in but not yet engaging? What were the sort of barriers to get there? We really tried to emphasize evidence-based behavioral health integration practices. Like Kaitlyn said, really focusing on the collaborative care model, because that is, I believe, amongst the most evidence-based. There's strong evidence that the implementing collaborative care model in its entirety really can help individuals achieve improvements in outcomes on PH conditions, as well as cost savings, and sort of is a cost positive model, I think, or a cost savings model for primary care. And then also we learned, I think, really early on in designing this program that we needed to be driven by what practices were focused on, what their priorities were. There's a lot coming at primary care, and Katie mentioned this before, there's a lot of demand as well as opportunities coming out of primary care practices right now, especially as they think about the ACO. So really, how can we leverage what they're interested in and help them meet their goals? And so I think that was really a bonus, I think, a really great thing to realize quickly, and allowed us to get a lot of traction in primary care practices. So I just thought it would be, certainly ask any questions, I thought it would be sort of interesting to report back what it is that practices were asking us. So these are aligned more or less with the PCMH criteria, the terms in orange there. But really, what were the technical and operational challenges that our primary care practices that were enrolled in our program were wrestling with? So when we talked about internal and external behavioral health providers, this, you have in your mapping to criteria B1 and B2. Practices were asking us around, should they build or should they buy in terms of behavioral health? Should they hire people, and if so, who are they going to hire? Or should they make relationships with providers in the community? And when? When do you buy and when do you build? Because I think that, as Kelsey noted in the changing of the criteria, there's always going to be a need, even for practices that have, even for community health centers that have robust behavioral health programs on site. There's still going to be a need for outpatient services. So what does that look like? And what really is the unmet need for patients? How do they segment the needs of their populations to figure out what is the top priority for them to address? And how does that relate to decisions about who to hire? Oh, and on who to partner with. On referral tracking, so what is the information that
What answer did
I said,
I'm curious.
I said segment your needs. So think about, is it the 80% of your patients that you really have a need with? Is it the depression and the anxiety that can be managed in a primary care setting, in which case it may make sense to hire social workers or behavioral health providers on site. But if it's really the people with SMI that you're worried about, the people who are going to be in your community partner program from S Health, then maybe you really should be thinking about strong relationships outside. And so I'm a big segmenter. I talk a lot about alignment, and I talk a lot about segmentation of needs. For referral tracking, so what is the actual information that people need? I thought Kaitlyn's presentation was great around. There's a lot of misperception or perhaps reality about barriers in this communication between primary care providers and behavioral health providers. But in fact, I think the information that people are nervous about sharing actually isn't what primary care providers need to know, right? Primary care providers need to know if they're on a medication. They need to know if they show up to their visit. They need to know if they're, if there's certain select pieces of information that primary care needs to know. So how do you get down to what you're asking for? And then how do you really communicate that to providers, and what do you offer? It's a two-way street of communication, right? So what are you offering to behavioral health providers that they also need to know, right? They also need to know the medication list, and it's not easy. It's not easy. Those communication channels don't always exist already. On the care manager on the team, likewise, who do you hire? It's a very different proposition to have a community health worker be a care manager. That solves one need. Having a social worker as a care manager also solves a need, but those may be different needs. So again, thinking really strategically about who it is that the care manager should hire, and what's the role, how do you integrate that case manager into sort of your existing primary care practice. For MAT providers, the practices that were enrolled in this cohort were not in a position that they were not practices that were not yet providing MAT but wanted to. So I think that could be a need that comes up that was not present in this cohort. But I think there was questions around how do you document your existing MAT program. BMC provides amazing resources for setting up an MAT program, but they may not have documented all the processes now, so that it's hard to sustain it. For example, it's hard to train new people. It's hard to make sure that you're continuing to deliver the best case, most evidence-based medicine if you don't have that documented. So I think we did have some conversations around that. I will say this cohort was not really focused on MAT, although I think that's why we're trying to push it a little bit there. Routine screenings for behavioral health conditions. This was a really fascinating one. What are screening processes? What are people screening for? What do they do with that information? I think we had a lot of conversations around once you screen positive, you want to make sure that you have a response there. We also talked a lot about screening frequency. So it is good to screen once a year at people's annual physicals. But it's actually, if somebody screens positive for depression, you get to start them on an antidepressant, right? And then it takes 6 weeks for that to kick in. Primary care practices are not necessarily routinely rescreening after 6 weeks to know if it's working, right? So with diabetes, managing diabetes as a chronic disease, primary care is pretty good at that, right? We rescreen every 3 months, and if the A1C is not moving, we change medications or we do something different. So the idea here is screen in a robust way, but also screen with a frequency that actually helps manage behavioral health conditions as a chronic disease in primary care. So that's sort of measurement-based care. That's one of the main concepts of the collaborative care model. The decision support, again, sort of segmenting the needs of the population and really developing responses that are tailored to, or developing guidelines that are tailored to both through the needs of your patients and the staffing resources that you have available. And then for care management referrals, sort of how do you use those screening processes, making sure that you have those resources available, and then what is really the role of the case manager. And then continuing to follow up again, sort of trying to get people toward remission of their depression, their anxiety, the conditions that are managed well in primary care. So this just shows, again, it's sort of what were people choosing to work on. So since we really followed primary care practices that were enrolled into what they're interested in, this I thought was interesting because it really was all over the map. So people were interested in different things. This does not add up to 20. partly because sites that have more than, there are health centers that have more than one site, they were sort of doing this centrally as we would hope that they would. But also that people had more than one priority, I think, really, thinking strategically about where to put their effort. And sometimes these align, sometimes you're working on both the screening processes and then the care management processes to back them. So I was just gonna give a couple examples from particular practices, but any questions on the overall? I know, Dr. Allen, we were very privileged to have you come to some of our learning collaboratives, so it was great.
It was very impressive to watch, so thank you for allowing me to do that. Now, I was a little, on the pie chart, I was surprised that more people weren't concerned about sustainability. And maybe they're just not ready to think about that yet. But that is, to me, it's a huge piece of it. Mostly because a lot of integration stuff is funded through grants and they run out, and so, how do you keep it up?
I would say those are people who really we asked them to commit to a couple goals. And so those were people who committed to that as sort of a goal for working with us.
I see.
I will say we did one webinar on financing, which really focused a lot on Medicare now pays for collaborative care in the primary care setting, and that was a very popular webinar. People had a lot of questions about it. Really I think people are doing hard thinking about how to invest in this way, in this system in a way that makes sense. I think they're talking to their ACOs about it as well. Whenever I was in the room, I said, this would be a great thing to talk to your ACO about. But I do think, and I echo, Kaitlyn's thoughts about, the reimbursement being high on people's mind, I think. But Medicare has opened the door for that a little bit, I think. I for one practice, ran some numbers about, what would it look like to try to fund a physician based on the Medicare reimbursement or partly funded of the collaborative care model. And I think it does open some opportunities, and I don't know if there's opportunities to expand that. I think that could be a part of the process.
I just want to add one point on that. I think it's the unit that we're working with here. It really is sort of the individual health center or the individual primary care practice that, as Myra said, is usually part of a larger system or contracts through a larger system. And so it's not that I don't think it's like top of mind for them. I mean, obviously with the advent of Mass Health ACO, and it certainly is top of mind. It's just, I think they're focused on more of the care delivery elements rather than the business side of it, which, maybe, I'm not saying whether that's right or wrong, it's just the point, right?
It was also not the CFOs I was meeting with.
Yeah.
I did see
Right.
Precisely.
Right.
So this is sort of one example, very sort of concrete level of engagement. So this is a small practice. It's a private practice. They don't have any internal behavioral health capacity. They do have a social worker who's doing some of their sort of case management work. They really wanted, their PCP says it's a huge waste of time and a huge concern for them when they refer their patients out. I can tell you they're on the Cape, so they're out to the providers on the Cape and they don't hear back. So then they either spend a lot of time trying to chase down the information, or they just don't know, and they're making treatment decisions assuming that they know, or the patients bring in their big bag of medications, which is a great start, good sort of patient engagement, but not always the most reliable. So the PCPs were really feeling like this was a major information gap for them. And so they took on a project which was, you want to translate it? This is criteria B1 in action. Really thinking about how do you leverage and how do you work differently with behavioral health providers in the community. So this was a draft, this was a picture of their memorandum of understanding that they drafted around what are they asking external behavioral health providers for, and then also how are they going to work differently? How are they going to share information? How are they going to make sure that the referral is done? How are they going to make sure the referrals are appropriate to BH providers, and that the BH provider knows why the patient is going, at least the clinical side of why they're going. The patient can, of course, self-report why they want to be there. But I thought it was a really interesting example. They did succeed at getting a behavioral health provider to sign this, which is great. And so I think it has the potential to really make a difference in how the way the information flows in that community. So they were struggling with, you see facts there. You see how these are not providers that are in the same system at all. They're completely independent. And so I think it was a great sort of exercise in building partnership and building collaboration at a community level. So this is from another practice. This is the registry. This is straight out of the collaborative care model. You can't see the details real well, but basically this is the practice that has existing processes for behavioral health and integrated case management. They have community work health workers on their team. They have behavioral health providers on site. So what they were doing is really adopting the registry tool to add a level of consistency, to establish treatment goals. What you can't see there in those middle boxes is it says sort of an initial PHQ-9 score, and it lays out what the target is. You're trying to get down to between a 5 or a 7 for a PHQ-9 score. And then it asks you to repeat it frequently. And what's the percentage change? So really using, bringing that level of rigor to the management of behavioral health conditions within the primary care setting. It also has a GAG-7 that does the similar thing. So what's the initial score? What's the follow-up score? Measured frequently. So I think that they were using this registry to really bring a level, sort of an evidence-based guideline to their behavioral health case management program. They were also working with their EHR vendor to build this in. Like this was already built in for diabetes, but it doesn't usually exist already for behavioral health conditions. So how can they leverage that technology to make it more automatic and more streamlined?
Does it do does it do something automatic like alert to the clinician if it's low or
well, it would.
follow up with the patient?
So this is an Excel spreadsheet.
I see.
So it would be the job of a person. I think that the goal would be yes, if they're trying to work with their EHR vendor to build this registry and then tie it to their existing processes and reminders.
So the whole thing about EHR vendors, frustrates me because I feel like there's one. So let's take Epic as the biggest vendor, and yet you've seen one Epic system, you've seen one Epic system. So, is there a role? I don't know. And this is a full separate question. Is there a role even that HPC can play to say to EHR to big vendors that we need some consistent tools that practices can use? How can we help to get there? I just feel it's like, why should each practice or each system have to independently come up with something that may not be the same as some different practice? And there's, just how can we learn from that when we don't have consistency? So that's just sort of really, I guess, sort of in the wilderness.
I think it's a challenge. I think EHR has come a long way on, for example, diabetes management. Anybody who has an A1C score above 10, they're going to have a banner at the top probably that says, you should recheck it every 3 months. And I think it's because there's a lot of agreement on what the standards are, and that there's processes to follow onto that. I think it's a great suggestion on,
It's the tool, just make a tool that works for everybody, and that in 2 different settings, the tool is the same.
Other practices we're wrestling with, where do I put this PHQ-9 score? What can I do with it that doesn't involve scanning the paper into the EMR, which then of course people rarely go find. So I do think that they're pushing the envelope in their own ways, and I think any help would be sure appreciated.
So I just want to do a time check. This has been a fabulous discussion. I want to make sure we can spend 2 minutes or so on the TA program changes and make sure the RPO thing gets presented. So
I can skip my last example. I will not.
No, I think just sort of giving us 1 more minute.
Okay. So this was sort of our other example. This is around really sort of helping practices really go through their process. Who is doing what? Who's doing screening? What's the follow-up? Which patients, again, to the idea of segmenting patients. Which patients are appropriate for the VA specialist? Is there a PHQ-9 score that triggers that? Bringing some of that, again, that through rigor to the process, and then making sure that everybody's on the same page about what the process is around integrated behavioral health care. And then, when are referrals outside appropriate? This is a site that didn't have a lot of internal VA capacity. So again, how do you figure out who's appropriate for your specialist, who's appropriate for an outside referral, and thinking about that. That's all I had. Thank you. Thank you for letting me do this.
No, well, we're thrilled to have Myra, and the HMA team has really been fantastic to work with. So, really the next thing that we wanted to share with you are some thoughts that we have on some slight modifications to the TA program in light of our overall experience with cohort 1. I think as you've just heard from Myra, we've learned that probably the most valuable thing that we can provide is practice coaching. It's the thing that helps practices really focus in the most in a really individualized way on their specific goals. So we've been thinking about how do we commit some more resources into practice coaching relative to the other aspects of the program that we had previously in the design. Second, I think the knowledge sharing session and the success of the peer-to-peer learning opportunity really reinforced for us that that's a really special modality and something that we could do more of, and that would be good. And then in terms of the another feature here of recorded webinars at this point, now that we've got them, we're interested in making them more broadly available. So in a nutshell, the overview of our proposed new design for the TA program is to really focus resources on those 3 areas. We're not intending to change the content of the program generally. We're still going to be targeting practices, primary care practices that are signed up for PCMH Prime. But we are going to expand the impact of the program a little bit by making those webinars more broadly available to any practice that's interested, as well as focusing on the knowledge sharing opportunities as ways to engage more practices in the program and in this work generally. And then with the practice coaching, I think what we're really seeing is that practices that are really motivated to do this work have these specific sort of tactical operational goals. And that we want to make sure we have good resources devoted to practice coaching. So I think we can accomplish this within the current scope of the work with HMA, and even be able to kind of right-size this investment and reduce the overall amount that we're allocating to this work without losing the impact. So this is just a side-by-side comparison of kind of our current approach versus the proposed. Instead of kind of focusing on cohorts that are 6 months each that are anchored by a learning collaborative or a couple of learning collaboratives, we're going to do a more one-on-one approach, offering practice coaching based on practices' needs. They'll submit a short statement to the HPC about what kind of practice coaching they're interested in, what sort of time they're willing to commit and are interested in receiving help for. We'll make the webinars publicly available, we'll continue the knowledge sharing sessions, but we'll kind of move away from the learning collaborative approach so that we're hoping that kind of reduces the upfront sense that practices have that they're making some kind of huge commitment right at a time that they may feel they have a lot else going on. So following on to our sharing this with you today, our plan is to work closely with HMA over the next few months to revise the contract, and then we will be rolling out the new TA program maybe mid-December, but looking at this and thinking about holidays, I would say really in earnest probably the first of the year we'll start to communicate this opportunity.
Thank you. Any final questions? Thank you so much. Thanks, Mark.
Okay, so what's next? Dave, do you want to do this part?
They're going to come up.
Oh, you wait.
Hi, everyone. Just a really quick update for you that Liz Reedy, the program manager for the registration of provider organizations, will give about our proposed additions to the 2018 data submission manual.
Great. So as you know, we're a first in the nation program for collecting public standardized information from the largest health systems in Massachusetts. We collected our first round of data in 2015. It's a public resource that's available on our website, and it's essentially mapping relationships that exist within the healthcare system. So we have data on corporate structure, contracting and clinical relationships, list of owned facilities, rosters of physicians. And in 2017, for this year's filing, we layered on some additional information on provider organizations' financials, contracting practices, and revenue received from APM contracts. And we're already starting to think about our 2018 filing. We're working to phase in the statutory requirements over time, and really want to have time to get feedback from provider organizations and from end users of the data. So for 2018, we're proposing 2 updates to our facilities file and to our provider roster. For the facilities file, which includes information on each of the provider organizations' owned licensed facilities, we're proposing to enhance the question that we currently have in the data set so that we capture more detailed information on which payers are paying facility fees to hospital, satellites, and clinics. This is an issue that's really gained a lot of attention recently. And payers have also noted to us the importance of collecting this information. So it should give us a better understanding of which facilities are charging facility fees by payer. We're also proposing updates to our provider roster. The provider roster currently includes information about MDs and DOs, and we're proposing to add certain advanced practice providers that are known to provide primary care services. So in this case, adding nurse practitioners, physician assistants, and certified nurse midwives to the roster so that we can better understand care delivery practices and access to primary care services in particular. So we will be putting our proposed requirements out for public comment. They'll be on our website in the next week or so, and we'll also email the proposed requirements out to everyone on our listserv and give organizations and other interested parties until November 30th to provide comments to us. So it's very fast. Are there any questions?
At risk of asking a stupid question. Just in going to the overview and the goal of the program here, would this also take into consideration the formation of ACOs and the clinical relationship with community providers? Is that captured all by this?
Sure. So we do have a clinical affiliations file currently. So we are intending to understand the relationships that provider organizations have with outside entities. We have pretty narrowly defined what is reportable in the first year of the program, given some feedback that if a provider organization were to report every clinical relationship that it has, we'd be getting 300, 400 relationships. But we are interested in getting feedback from, and actually one of the specific questions that we've included in our memo is a question about with the coming about of new care delivery models and payment models, if there are new types of clinical relationships that are important and that should be captured in this data set, whether in lieu of or in addition to the types that we've focused on in the past.
One other data point I'll add, again, not part of RPO and the public, but through ACO certification, they do have to report in their cross-continued relationships with LTSS providers, BH providers, specialists, and hospitals.
Okay, thank you. So, my hands are started by okay. I'll just say it's been an honor to chair this committee. I'll stay in touch. And so thank you for being here. So, adjourned.
So we'll take just a 5-minute break and then come back for the next set of committee minutes.
Okay, come in.
Magic. I know.